what we're talking about today is a huge intersection of all these service providers, all of you who are in the room. And just by way of background, it's not in the bio, but for the first 30 years of my career, starting as an undergrad, now almost 40 years ago, I started as a psych tech in a psych hospital, in a private psychiatric hospital in a suburb of Kansas City. And since that time, for the next 30 years, I worked in the field as a clinician, either in mental health settings or in substance use settings. So the work that you're doing as clinicians, as providers, is really the bulk of my history. And then about 10 years ago, I ended up in government, sort of serendipitously, with moving back to Kansas for some family medical issues, and ended up being the manager or the director of the state substance use system in Kansas. Lo and behold, then I got recruited back to the West Coast, to Washington State, where I was the director of the Division of Behavioral Health and Recovery, which used to be the Division of Alcohol and Substance Abuse and the Division of Mental Health, but I ended up having to, with my staff, merge those two divisions. So, and then 5 years ago was recruited into federal service. So what I say with all of that is that the background of my thinking when I think about policy in this arena is very much informed by my personal clinical experience over a 30-year career delivering services in outpatient, inpatient hospitals, et cetera. So what I'm going to try to do today is not, because I realize now that I stand between you and lunch, number one. So I always love being in this position. But not only that, you know, like Dr. Phelps and Dr. Smith said, I could talk all day on this subject or related subjects, and I don't want to do that. And I also do not want to create an environment of death by PowerPoint. I could easily do that. So I want to try to, I'm going to clip through some of these slides fairly quickly because I want to give you a snapshot. You saw snapshots from Dr. Hedberg and from our senator, who showed us, you know, what's the on-the-ground realities around particularly the opioid crisis, the opioid epidemic in the state of Oregon. So I'm going to elevate that a little bit to the 30,000-foot level, if you will, show you some data, show you some snapshots for what we see at the national level. And by the way, part of the reason I'm back on the West Coast, which is where I've spent most of my adult life, both in clinical work and out here, is that my wife's a Portland native. So I usually tell folks that I have a mom in Kansas and a mother-in-law in Portland, but I really know who it's important to keep happy. And so we live in Olympia, Washington, and our kids are, one's still in Olympia, one is now back in California in her college career. So try to talk about the scope of the epidemic, try to talk with you about some of the national initiatives that are going on to address this. Some have already been mentioned today, in particular the CDC's opioid prescribing guidelines, and then some resources offer this. And there's a whole bunch of slides. If you looked at the slides, if you downloaded them in advance because they wanted me to send them in by Monday and you got scared, it's okay. What I try to do is give you more information than I could possibly cover in the time that I'm allowed, so that you then can have time to, you know, take it back, look at it, digest it, and think about the things that are important to you. So, opioid prescribing has quadrupled, and this is just in the last 15 years. Well, from 99 to 2014, so I don't have the most current. But since we're talking about pain, what we see and what we know is that, and you see it every day in your clinical practice, is that people continue to report the pain and that the pain is unchanged. And I'm really glad that we're talking about alternative approaches, and there's already been a lot of discussion about alternative approaches. We also know that in this opioid epidemic, we have a problem with heroin. We have heroin running up and down the I-5 corridor. It's like a mainline channel for the cartels to deliver heroin into our neighborhoods, into our communities, into our cities. And that people who oftentimes become addicted to opioid medications, but then can no longer get them because their doctor will no longer prescribe them. They've shopped different docs, you can't get them, oftentimes turn to heroin, which is cheap and initially perhaps takes care of the issue of withdrawal and avoidance of withdrawal, but it leads to other things. And so you see at the far right end of this screen that people who are addicted to opioid painkillers are 40 times more likely to be addicted to heroin. That's a frightening data point. So 3 out of 4 people who used heroin in the past year, they used prescription opioids first. They abused them, not just used them. Maybe they weren't even prescribed. You've all heard about farming. We've been talking about farming with a PH for a lot of years. You know, when our children go into the medicine cabinets of their parents, their grandparents, neighbors, and they seek and obtain prescription narcotics. And so the abuse happens first, and then we lead into heroin. And that we know that 7 of 10 people, so 70% of the folks who've used heroin in the past year also abused opioids. I think this is an interesting thing, since I was kind of asking about specialties so that I kind of got a flavor for who's in the room. You can see the opioid analgesic prescriptions that are dispensed, and you can see who the prescribers are. And by and large, the largest number of prescriptions have been primary care docs, and over the years, you see the level has not changed much for primary care. You see, and then I think this is an encouraging sign in pain medicine. So those of you who are working in this field, who are already knowledgeable, who are thinking about this, who are doing things like PainWise and this consortium of providers, the folks who are actively engaged in pain medicine right now are among the lowest of prescribing. And you're thinking about this, and you're thinking about it with consciousness and awareness. And so that's really encouraging data. When you look at the United States, there can be a threefold variation in prescribing in the states. And so I know you're all probably looking up there at Oregon, and you see that it's purple, so it's 82 to 95 painkiller prescriptions per 100 people. That's a significant number. And you saw some data earlier from Dr. Hedberg that spoke about the number, I think Oregon being number 4 in the United States relative to this issue. So what does it lead to? We've talked about overdose, we've talked about naloxone to reverse overdose. You can see here the correlation between opioid sales, so those prescriptions that are going out onto the street, into the hands of your patients, our family members, are leading to elevated opioid deaths. And here are the rates of heroin overdose by age. And I think that these 3 lines kind of reflect something that was said, I think, earlier, maybe by Dr. Hedberg, about people in the prime of life. So the 3 graphs, the green line is the 18 to 24 bracket. The dark blue line, that's the highest death line, that's had the sharpest spike since 2010, is 25 to 44, people in the prime of their lives. And then that last light blue line, that's the bracket that I'm in now. And even among those of us aging baby boomers, we see, and I can certainly relate, as I get older, I have more pain. I'm a polio survivor. I had polio as a child, and so there are things that emerge with age that I didn't feel so much when I was young. And so how do I manage that? How do I do the pain control if I have a chronic condition and not want to get myself into an addictive situation or a potential overdose situation. This graphic shows you heroin addiction, specifically the light blue in the bottom is the heroin addiction from 2002 to 2013. This is, in much of this data, I think I tried to reference on all the slides, the data sources. This is National Survey of Drug Use and Health, which SAMHSA does and funds every year. And it's nationwide and it's extrapolated by population. So you see the heroin addiction, or what we might now call opioid use disorder. And then you see the deaths, and a 286, almost 300% increase in heroin-related overdose deaths. You know, this is clearly a public health crisis. It is an epidemic of extraordinary proportion, and you know, to me, when we lose nearly 50,000 people annually in this country, it becomes a real priority. It's a priority, I think, for us as a federal agency, and you see and you heard from Dr. Hedberg and from the Senator how much it's a growing priority here in the state, and I think really across all states. So I like these just because the visuals, the next, like, I think 3 or 4 or 5 slides are kind of visual. So these next 3, just look at the increase in drug overdose death rates. So in this, the dark blue represents the lowest, and the dark red, as you shade through the colors of the rainbow, if you will, is the highest overdose death rate. This is a county by county map of the United States in 2002. Jump 5 years forward. There you go back again to 2002. How much blue? How little red? 5 years forward. The blue is shrinking. The middle colors, the yellows, the oranges are growing, and there's significant growth in the red. 2014. The blue is almost gone. We're almost all now moving into other shades along the spectrum towards red. I think when we see these, and again, this is all public available data, you're going to have the slide deck. As you go back to your workplaces, as you go to other associations, organizations, work that you do, affiliations, as you think about some of the comments that our Senator made around pending legislation, these are tools that you can use as you think about it and as you think about what you may or may not want to do relative to advocacy. As a federal official, I can't advocate, but I can provide education, and hopefully that's some of what you get to do with these as well. Another snapshot. So this is sort of that same time frame. The earlier slide started with 2002 up to 2014. This is 10 years between 2004 and 2014. So you see the side-by-sides with the drug overdose death rate increase, and again, sort of that population density figure. And it's not just in the East Coast, it's not just in the West Coast. You see large concentrations in other parts of the country. This is just another way of graphically looking at the opioid epidemic across the country in the last 14, 15 years. The top line is deaths involving any opioid, and then it's broken down below it into the natural and semi-synthetic opioids, so the oxycodones, the hydrocodones, et cetera, and then you get down towards the fentanyl, the carfentanil, which is really frightening to me. I don't know if you know, but you can actually order carfentanil from China online and have it delivered. So we're having these pop-up spots of overdose clusters. For me, it's a little bit like how I deal with in our region suicide clusters. We're having overdose clusters in communities in Indiana or Ohio. I haven't seen it happen here yet, where people are getting carfentanil, and you all in this room know that fentanyl is 15 to 25 times more potent than morphine or heroin. Carfentanil is another magnitude, significantly more higher, and you can mail order this stuff. So dealers are cutting heroin with fentanyl or carfentanil. Users are getting a product that they think is heroin, and they're overdosing. And when we talk about the use of naloxone to reduce overdose, it's not going to work with a single treatment of naloxone. I've heard of multiple episodes of people having to have naloxone 2, 3, and 4 times in order to reverse the effect, to have the antagonist effect that naloxone has, and to reduce the effect, and to sort of, as was said before, sort of shock the person back into life from the edge of death. So I think other trend that I would mention there, the bottom line there that you see, that the only one that's trending down is methadone, which I think is good news on a couple of fronts. One, it's one of the 3 primary medications that we recommended that is used in substance use disorder medication-assisted treatment. It's probably the oldest and most familiar to people, and it, of course, is available as an agonist for abuse and for diversion, similar to buprenorphine, but we're seeing that trend down. And I don't know what that trend is about. I don't know if it's because there's so much other stuff available on the streets now, and so people just don't even bother with methadone, but at least there's one downward trend line. And this is just a gender comparison. So again, look at the time frame. Women were pretty well flatlined for the first 10 years of this century, and then they started to trend up, and about that same time in 2010, men just spiked in terms of overdose deaths. So it's all of these pictures are just ways to tell you, to frame for you what you're already knowing. Here's another way of looking at the relationship between sales of prescription narcotics and the rate of overdose deaths. So again, if you want to focus on Oregon, you can see that it's got the 3rd highest rate of sale or prescription of opioid pain relievers. It's in that 3rd dot category, but yet it's still down in the lower category for drug overdose death rate. So even though we have an epidemic here in this state, it's not quite as bad as it is in some of our neighboring states like Washington to the north, or even Alaska, which is one of the states I serve. I like this because, and I think you will relate to it, it's the primary care physician's views on prescription opioids. And I like it because I think it reflects what's happening in this room today. And that is that most, the vast majority of primary care docs now recognize and regard prescription opioid abuse in the community as a large magnitude problem, and they also recognize that it has historically been overused for pain. And so to hear you all talking about alternatives for pain management and all the different approaches, and to have you come together as you have in this organization of PainWise is really encouraging, and I think it's reflective of this. You also heard in earlier comments by Dr. Hedberg and by our Senator about the woeful lack of treatment. We're hoping to address that here in partnership with the state of Oregon, and you heard a little bit about that, and I'll say more. This is the treatment admissions data that we get. We get what's called treatment episode data sets at SAMHSA annually from each of the states, who get it from all of their providers, and all the providers submit this data. So you'll see that still the primary treatment admission drug of abuse is alcohol, but close behind it in terms of a second place is heroin, and 3rd, marijuana. And for men, marijuana is actually a higher treatment admission rate than heroin. So you see the top 3 relative to drugs of abuse, and then you see how things go down. But what you might also note is prescription pain relievers in the black column. So if you actually put the prescription pain relievers with the heroin, then you would be rivaling, or getting closer to the alcohol abuse, alcohol disorder treatment numbers. And I think that that's significant too, because what it means is when I think now about heroin and when I think about prescription opiates, I blend them in my mind in terms of the language of opiate use disorder. And for me, as a former clinician, as somebody who worked in detox, who helped develop buprenorphine protocols and treatment settings, who in an agency that I was a director ran methadone and actually had needle exchange on Friday nights. When I think about this, I think about the spectrum of opioid use disorder and how much that has grown relative to prevalence in the treatment world. We used to see a lot more meth, a lot more cocaine. Now it's opiates, and significantly more opiates. So capacity is not enough to meet the need. The numbers that we get annually increase, but it's 22.5 million. That's a lot of people in this country who need treatment, and on any given day, we're only getting about 10% of those folks into specialty treatment for substance use disorder, whether that's for alcohol, whether that's for opiates, whether it's for cocaine, or a combination. We have lots of people who are using combinations of substances, which I think points to, again, one of the things that's important about this meeting today, and maybe this conversation, is that one of your tasks, and it's in the guidelines that Oregon has around prescribing, and that the CDC has now put out and promoted nationally, is to have that conversation with your patients as you're prescribing, and talk with them about the risks relative to the substance being prescribed. And hopefully at a preventative level, we prevent more and more people from entering into a dependency or a substance disorder. So what are some of the national initiatives? I tried to put these, and I'm going to apologize. I was working on this on a plane to DC last Monday, and so some of it might be a little jumbled, and I'm a little bit jet lagged today because I got into PDX late last night after a week on that coast. And let me tell you, folks, it is really good to be home. I mean, you know, driving down I-5 and just like being in familiar territory. And that probably covers a lot of things. So if it's a little jumbled, or if I come across a little jumbled, you forgive me for my jet lag. But the department I work for, Health and Human Services, which SAMHSA is a part of, convened a scientific workshop in 2014, really looking at the risks, looking at best practice guidelines for long-term use of opioids in pain and management, looking at the adverse effects of opioid use, misuse, et cetera, and to really try to accelerate and enhance research efforts and get to the best translation of that research into good practice. This is my bad. I was actually changing these slides and realized I wasn't going to get them here because they'd already been downloaded. This should say Department of Health and Human Services, 2015 initiative now. If you don't follow the news, and I try now not to watch a lot of news. I didn't even turn on the TV last night or this morning. But our secretary is now Secretary Tom Price, the congressman from Georgia, who was confirmed yesterday. But the initiative remains the same. And what are we focused on? We're focused on training and providing educational resources to providers, physicians, and all the way across the spectrum of treatment providers. We're focused on expanding naloxone, and we're focused on expanding medication-assisted treatment. But this started under Secretary Burwell. And this is the CDC infographic. And again, if you want to take these slides, download them, print them, put them in your office, use them as reminders, it's basically saying the same thing. Prevent people from starting heroin. How do you do that? You know, by improving the prescribing practices. That's that education piece. Reduce heroin addiction. So ensure greater access to medication-assisted treatment, and then reverse heroin overdose. So it's just another way of saying the same thing, and you'll see in a later slide, it's the same language that we use at SAMHSA. So it's been consistent from the previous administration in the White House through the department, through SAMHSA, and SAMHSA is a sister agency with the Center for Disease Control and Prevention in HHS. We have a lot of partners, and some of you raised your hands as nurse practitioners. The American Association of Nurse Practitioners and multiple nursing organizations launched an initiative really focused on combating opioid abuse. That was in 2014. You can see a list of all the partnering groups and the link to the CDC guidelines there. So they're really encouraging across their membership awareness of and learning about these prescribing guidelines. They have also been supporting, these national nursing organizations have been supporting through an expert panel convened by the National Institute of Drug Abuse, the development of training modules. Harvard University has been awarded the contract, if you will, to develop those clinical training modules around substance use disorder for nurses. And I'll just say, you know, from a training perspective, you know, when I was in my graduate work in psychology, I found it extraordinary that in a cohort of 40 other people who were ranging in age from, say, 25 to 40 years old in a graduate degree in psychology, that there was one 3-hour course in basic addictions. And when we met in that first class, the only person who raised their hand who had any knowledge around substance use disorder was yours truly. That's frightening to me because it's an indicator to me that we need to do a better job in nursing schools, in medical schools, in programs for psychology, in making people aware of the impact of substance use disorder, in making people aware of the comorbidity of substance use disorder and mental health diagnoses, as well as the comorbidity with other chronic disease, whether that's diabetes, whether that's COPD, whether it's kidney disease, whatever it might be, and we need to do better at that. So I'm really encouraged by this work by the nursing associations. There's also now a new subspecialty in addiction medicine, and that was just announced in March 2016, recognized by the American Board of Medical Sciences. I'm not going to read all that stuff, but you can see what the core competencies are that are listed for addiction medicine. And we as SAMHSA regional administrators, and I should mention, I'm an office of one. I serve the states of Alaska, Oregon, Idaho, Washington. Our offices were just created 5 years ago. And I also have 271 federally recognized tribes in my 4 states. So we have almost half of the federally recognized tribes in our 4-state region. But we are, across our regions now, beginning to work with and have conversations with. First, it started in Region 3. Conversations have happened in Region 7, which is Kansas City. Region 3 is Philadelphia. And I've had initial conversations with Dr. Kevin Kuntz from the foundation, talking about creating fellowships for addiction medicine in our medical schools. And you all know we don't have a lot of medical schools in our 4-state region. But if we can create some fellowships that train more people around substance use disorder or addiction specialty, that would be great. I'm going to talk about a couple of pieces of legislation that passed in 2016, one in the summer and one after the election. And I'm also going to talk about briefly this little item, Facing Addiction in America. The Surgeon General's report that came out in November, was launched November 17th. And I apologize because when I was putting those slides together on the flight Monday, I forgot to put in my slide about the Surgeon General, thus my handheld device here. So how many of you heard of the Comprehensive Addiction Recovery Act? 1, 2, 3. Okay, let me say a little bit about this. This is the first significant piece of legislation related to addiction treatment and recovery in 40 years in the United States. It passed almost unanimously in the House and the Senate in the summer, and it outlines a whole array of, without getting into the bill, and I think I have in another slide the link if you want to look at more detail on the bill, whole array of things that we want to do to improve access to treatment. The problem with this bill was that Congress only appropriated $37.5 million to SAMHSA to do that treatment expansion piece. That's sort of a drop in the bucket. And you remember in the previous administration, the previous president had asked for $1.1 billion in FY17 and FY18 to fight the epidemic. But there's good news to come. Before I jump to that, though, notice the implication for nurse practitioner. If you're a nurse practitioner or a PA in this room, or you know folks who are interested in this, they should be aware that they will now be able to be prescribers by taking the 24 hours of required training and doing the application to our agency, getting a DEA number, and then being a prescriber. That should help expand the workforce of folks, so that it's not just physicians who have gotten the buprenorphine waiver, but an increased workforce of PAs and MPs that can do that as well. Here's that little quick list of national initiatives. So 46 of the 50 governors have taken a pledge on combating the opioid crisis in our nation. SAMHSA did a notice of proposed rulemaking to change the limits for buprenorphine prescribers. Is anybody in here a waivered buprenorphine doc? 1, 2, 3, 4, 5, okay, a few of you, 6. So you know that in the beginning, when you got your waiver, you could treat 30 patients in the beginning, and then after you had done that and were successful with that, you could apply to SAMHSA and you could get it bumped up to 100. This rule that was finalized over the summer raised that after we did a public comment period and a notice of proposed rulemaking. It is now 275. So physicians who are waivered will be able to apply for and go up to 275 patients. And we are getting a lot of those applications now from people who specifically work in the field of substance use disorder treatment. And that other previous slide that I talked about on the Comprehensive Addiction Recovery Act will allow the nurse practitioners and PAs to get that same waiver, but for the 30 and the 100 level of patients. So I've already mentioned the CARA. We call it CARA. I'm trying to not speak in acronyms too much because that's all we do in government is speak acronymese to one another. It's all shorthand. But the Comprehensive Addiction Recovery Act, you see the link there, so if you want more detail on that. I've already mentioned, and you heard from Dr. Hedberg this morning mention of, and you've already probably seen the CDC's prescribing guidelines. All of this has happened just in the past year, 2016. And then the 21st Century Cures Act, last, certainly not least, for us. And the one that I forgot to put in there, and I was trying to alter it last night, was the Surgeon General's release of this report, Facing Addiction in America. Really a comprehensive document. This is just the executive summary. You can download this, and you can download the full document from our website or from the Surgeon General's website. And I encourage you to do that, even if you just want to take a look at it or have it available, share it with colleagues. So that was November. The CARA Act passed in the summer. And then after the election, and this is what's really extraordinary, folks. This is what's really extraordinary. After the election, the folks who are working on the 21st Century Cures Act, the President's BRAIN Initiative, the previous President's BRAIN Initiative, the previous Vice President's initiative around finding cures for cancer, and really elevating the research and moving more quickly to do that. It got folded in with Congressman Tim Murphy's Helping Families in Mental Health Crisis Act that had been in Congress kind of winding its way for a couple of years. And those two bills together passed, again, almost unanimously, after the election in the House, the next week in the Senate, and the following week was signed by President Obama. The day after it was signed, and this is what's really extraordinary, besides that bipartisanship that happened in this environment that we all live in now, to see people come together and recognize behavioral health issues as a comprehensive component of overall health issues, to have that happen on a bipartisan way. The other extraordinary thing was we saw the trend. We saw the way the vote was looking. And at SAMHSA, the day after the president signed the bill, we released the funding opportunity announcement, which you heard mentioned in the earlier presentation about the grant that the state of Oregon is applying for. In fact, all states. And with it, they didn't just pass the bill, they funded the bill. So whereas CARA wasn't funded in the summer, this bill that passed in November gives $1 billion over FY17 and FY18, $500 million each year to the states through SAMHSA. There's a whole, on that website, if you want to go look at the bill, you can see the breakdown of how the funding goes to states. And every state is eligible for it. Oregon, Washington, all of my states, all 50 states. Any states who don't apply for it, whatever's left of that money just gets folded back into the pot and redistributed. And it's really based on the opioid use disorder prevalence in the states, meaning how many people meet the criteria of opioid use disorder but can't get treatment, and then the CDC's mortality data for drug poisoning deaths. Those were the two drivers. So it's not population driven. So even though Oregon is a smaller state population-wise, it gets a little bit more money because of the prevalence of the epidemic here. So you see that if you look at the chart. So just really good news there. And so we call it, this is the slide about that grant division. I'm not going to go into all the detail of it. I just mentioned the amount of money for it, but it's out there on the street. All states are applying. The close date for it, we posted the FOA mid-December, and states had 2 months, and you saw what was going to be included in Oregon's relative to the things that they want to do. It's not a template. Every state can design their own grant program. It's highly flexible. So, you know, some states like out here that have larger tribal populations, as Oregon is doing with their application, is focusing more on tribal communities. And what are we doing? Obviously, we're putting it out. We call it Opioid STR. There's another one of those wonderful acronyms, State Targeted Response to the Opioid Crisis. We've already talked about this, but what you may not know is that 60 medical schools, and I'm sure that number has grown by now, at the time the CDC released their guidelines in the fall, they said, we are now incorporating this into medical school curriculum. If you want to be a doc and go to our school, graduate with a medical degree, you will have prescribing guidelines as a matter of coursework. It will be required. And I anticipate that that will continue to grow. So partnership between CDC and medical schools, partnership with pharmacy. Look at the number of pharmacies and the numbers of pharmacists. And I know we had some pharmacists in the room. Rite Aid, Kroger, AmerisourceBergen, Good Neighbor, and all of them increasing access, making it possible to have naloxone prescribed and available through their pharmacy. I anticipate that this will grow. Having the availability of naloxone, not just for first responders, not just for police, not just for EMTs, but for family members, for someone who might be taking a prescription narcotic for pain management and is at risk. You know, having that training, having that awareness will be critical, I think, going forward in time. So again, you've seen these before under the department, you've seen them under the CDC infographic. What we're trying to do, and we're trying to do that in a public health approach that's multidimensional. SAMHSA for a long time has talked about the continuum of care, from prevention through treatment, all the way to recovery. And what I have said for a number of years in my work, and it's informed by my clinical background, if we do a better job on the front end, preventing people from getting into substance disorder, and we do a good job on the back end supporting those who may have become addicted and then found their way to recovery, we're going to collapse the treatment need in the middle. We're going to have healthier communities, healthier individuals as a result of that. And then, of course, we've added in that component around rescue, overdose prevention and rescue. So I'm not going to spend a lot of time on these next few slides because I think you already are going to have a presentation this afternoon. I saw on the agenda around medication-assisted treatment. So basically, I'm just going to skim through them, but you know, what the definition of it is, you know, from our perspective is, and it's happening here. You're talking about it in this room. You're making sure that if you're delivering MAT, if you're doing that as a physician, as a treatment provider, that you're connecting with behavioral health resources, so that it's not just about giving Suboxone or buprenorphine or Subutex to the patient and saying, be on your merry way. You're not going to be having cravings. You're not going to go through withdrawal today, as long as you take your pill. There's other things that go with that, you know, and particularly when we think about pain management, you know, the things that we can do like massage therapy, like yoga, like physical therapy, et cetera, that help us, you know, DBT, et cetera, that help us manage. And so having that is critical. So you know already the medications that are approved by the FDA: methadone, buprenorphine, naltrexone, the long-acting injectable. And these are the essential benefits from our perspective of medication-assisted treatment. You reduce all-cause mortality, reduce the risk of HIV, it increases medication adherence, improves social functioning. So you have people, and I've seen this because I've done both buprenorphine and methadone treatment, people who are in maintenance modes of those medications suddenly are able to no longer be addicted to whatever it was that they were using and to be functioning members of society, maintaining their family life, maintaining their employment, and not winding up in the criminal justice system or homeless or otherwise in bad situations. So a little bit about detox. It should be under close supervision. And we know that when we detox folks from these medications, there's a risk of relapse. So detox isn't treatment, but it can be, on the front end, a pathway into treatment. And I've seen it and I've done it as a provider. So you already know, you're going to hear more about methadone this afternoon, buprenorphine. The combination, and I think this is important to any of you who work with women who might be pregnant, and some of the advisable things, that either one can be used during pregnancy. Not advisable to switch the medication if they're already doing that during pregnancy. And you always think about the individual patient relative to what you initiate. SAMHSA supports and has the oversight for outpatient treatment programs for methadone and now for community-based buprenorphine. So there's that. We've already talked about waivered providers and the numbers involved there, and I mentioned the rule change that raises that for physicians to 275, and that now advanced practice nurses and PAs can get that waiver as well. And then I can't emphasize enough the importance of recovery. Supporting, if you're working with patients who actually have a substance use disorder identified, helping support them in their recovery and to maintain their recovery as they manage their pain, particularly if they're using some opioid medication in a limited way to manage pain, to manage a short-term flare-up. It's just really critical that we think about recovery in terms of the maintenance of health, the maintenance of home, and a purpose in life. I want to mention another sister agency, the Health Resources Services Administration. I actually share office with them in Seattle. They fund the federally qualified health centers and the community health clinics. How many, is anybody here at FQHCs? Or, okay, one, two, couple. So they released $94 million to expand substance use disorder treatment, including MAT. And then lastly, I want to just put up some of the resources that you can get through samhsastore.gov. We put out treatment improvement protocols. So here's one, what we call Tip 54, Managing Chronic Pain in Adults with or in Recovery from Substance Use Disorders, which is just what I was talking about. If you're working with a patient or client who has a history of substance use disorder, this can be a helpful guide for you. We have new research continuously emerging in this arena, and I'm sure many of you are reading those research documents. SAMHSA has a number of epidemiological tools. The Center for Behavioral Health Statistics and Quality in our shop is the one that does the survey and the data gathering and the compiling of that. So you can look at population level data and drill it down. We have a lot of frontline support services, a lot of training modules that are available online. We have treatment locators, and if you go to the homepage of our website, you'll see on the right-hand side treatment locators, and underneath, when you click on that, you'll see specific locators for waivered physicians and for the methadone providers. So if you know somebody who needs those resources, it's readily available, and you just click on the state and find who in your region has those needs. This is the oversight agency or division within SAMHSA, the Division of Pharmacological Therapies. They are the ones who oversee the waivers. They are the ones who oversee the methadone programs. And they have oversight for all the guidelines and the resources. The training is available online, the 8-hour training for docs, the 24-hour training for NPs and PAs. We also have something called the Provider's Clinical Support System, or PCSS, and we have now sort of specialized that with specialized trainings for MAT and around opioids, a special website on opioidprescribing.com. Again, more tips, treatment improvement protocol for medication-assisted treatment. We created, in partnership with a lot of researchers and folks, maybe some of you know Dr. Caleb Banta-Green from the University of Washington. He was a contributor to the development of the Opioid Overdose Toolkit, which is a really helpful toolkit that can be available to families and help guide them and walk them through how to not only prevent but also respond to an overdose. And an educational resource for consumers around chronic pain. If you're in recovery from mental illness or addiction, or both co-occurring mental illness and substance use disorder. The conversation that happened earlier about sharing of data, as many of you know, has been inhibited for a lot of years by something called 42 CFR Part 2, which is specific to substance use disorder treatment data. We did public comment in 2016, and we're preparing to revise that. Actually, the rule was finalized and posted to the Federal Register on January 18th. Note that date, January 18th. Inauguration was the 20th, and the ensuing executive orders have put that under review now. So we were hopeful of having it go live in February. It may be a little bit later now, because I think the executive order placed a 60-day hold on all new rules being implemented. You can see how many downloads we've had for the toolkit, for the Provider's Clinical Support Tool. You can see the numbers of physicians, and that number is actually higher now. It was 31,000. And it's higher than that because more physicians are getting their waivers. We've put out a whole boatload of grants. Oregon has at least one, and probably will have a second shortly. This one was around prescription abuse and reducing that through the use of PDMP data. We've put out overdose grants. Washington State in our region got one of those, and they're working to expand the availability of naloxone in rural communities across Washington. We put out, and this is the one that Oregon just got last September, we call it MAT-PADOA. It's a prescription drug and opioid addiction MAT grant. And so there was $25 million that went out to 23 states focusing on high-need communities. We've distributed 10,000 of these little flip chart hand guides for physicians that really side by side show methadone buprenorphine, naltrexone, show clinical indicators, show recommendations. Thank you. Just about out of time, which means there's not much time until you get lunch. And this is the website for the SAMHSAstore.gov, which all of those resources I showed you are available online. You can create an account. You, like I, am a taxpayer. We've already paid for it, right? So get it, use it, and I just want to acknowledge some of my colleagues in different branches, and lastly, my contact info. And again, all of this is available, and we have a few minutes left for a couple questions. Yeah.